Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello and welcome to the latest episode of Talking Meds. I'm joined today by an old colleague of mine, and I'd like to say friend of mine as well, Andy Hutchinson. I've known Andy for getting on for 30 years now. We were actually at Sunderland, as it was Poly, together, doing pharmacy. He was in the third year when I was in the first year, so he's a couple of years older than me, but we'll leave it at that. Andy now works as the principal pharmacist clinical advisor in the medicines optimization team at NICE. He has a background in hospital and primary care pharmacy and has a particular interest in education, patient-centered care, and especially shared decision making. You can see why we get on now, can't you? Because as you know, listeners, I have a similar interest in person-centered care and shared decision making. As I say, Andy and I have worked together for years. When I was at the National Prescribing Centre, we recruited Andy to be an NPCi trainer. And then Andy helped Neil Maskery and I develop NPCi, which was ahead of its time, I have to say, e-learning platform for prescribers to keep up to date with therapeutics and medicines optimization challenges, and indeed evidence-informed decision making. After that, Andy became an NPCi trainer, helped us develop that NPCi trainers network, which then evolved into the wonderful NICE Medicines and Prescribing Associate Network that Andy manages now. I'm going to embarrass him now. I think Andy is probably the leading pharmacy educator of our generation. I've learned so much from him over the years. He's one of those people who's really steeped in educational theory. And Neil and I would say, oh, how about we do this in terms of an educational intervention? And Andy would say, oh yes, there's evidence for that from educational theory. That's probably a good thing to do. So as I said, we've worked together a long time. We work well as a team together, and I'm delighted to have him here on the podcast. We're going to talk today about what we've called the lost NICE guidelines. I'll leave it at there and we'll explore that, what we mean by that in a minute. But Andy, I know I've embarrassed you there. I know you don't take praise easily, but just to say thank you and welcome and thanks for joining us.
Blimey. I am embarrassed. Yeah, thank you so much, Jonathan. Yeah, it's great to be here. I'm a great fan of the podcast. It's great to have heard, well, all the guests. They've all brought something different and something really interesting and what we're going to talk about today, actually, if listeners have enjoyed things like the series with Lucy Pollock and Sundus and Adam Todd, which was just the last one before we're recording this one, you'll really like what we're going to talk about today, I think, because it all links together. You could almost think it was planned, couldn't you?
You could, not just thrown together, to steal that from another podcast we like, Mr. Steve Williams. Thanks for that. So Andy, tell us a little bit more about your career journey so far and your highlights.
Okay, so as you said, I was at Sunderland. Then I went to Leicester Hospitals for my pre-reg. And then I went to Cardiff to do medicines information, drug information as we called it then. So I was at the Welsh Drug Information Centre. And the reason I really went to Cardiff was to do a clinical diploma, because back then, and this is sort of like end of the way back in the last century, there weren't many clinical diplomas around at that point. But I realised that my undergraduate course, where I could describe the release of a drug from a slow release matrix and tell the difference between Tinnavelli and Alexandria and Senna, probably needed a little bit of a top up for the way things were going in pharmacy at the time, really. So I had a great time there, and then I really liked drug information, medicines information. So I went from there to Colchester to run the Drug Information Centre there. Had a great time in Colchester. It's a lovely place, not least because I met my wife there, so that was grand. But I was getting to the point where it was like, I'm gonna have to move for a different job, or I'm going to be here for kind of like the duration kind of thing. And this job came up in Leeds, principal pharmacist, drug information, clinical trials at St James's, Jimmy's. Brilliant, ideal job. So I said to them, aren't you having this merger of trusts? Yeah, it'll all be fine. Don't worry, it's all fine. So moved my young family. So my son wasn't even born when I got offered the job, and he was only a couple of months old when we moved. And in that interval, yeah, things had gone a bit different, really. So cut a long story short, the job I came to do wasn't there after a few months. Okay, what do I do then? Right, okay, well, DG got a job in this primary care group that was being set up. No one really knew what these things were going to be. It was all part of the new Labour reforms, but I kind of took a punt. And of course, PCGs became PCTs, forerunner of CCGs and ICBs and whatever. So I was kind of in at the ground floor of that development in primary care pharmacy. So it was a really difficult time, not least because my mother died suddenly, unexpectedly out of the blue as well. And I'm saying all this not for the poor me, but I know at the moment things are tough for colleagues in a number of sectors, particularly ICBs. And I just sort of say, be encouraged. You don't know what might turn up. I know that sounds like Mr. McCorber, but you don't know what will turn up. And do you remember, Jonathan, years ago, I think we did a podcast for CPPE about, what would you say to sort of new pharmacists, new qualified people? And I think we said, well, try different things, take a sideways move, put your hand up for stuff. And certainly that's been my career experience. So I would say be encouraged, people. Anyway, so yeah, as you said, Jonathan, got involved in NPCi, was a trainer. I did a postgrad certificate in clinical education from Leeds Uni, which was really good. Another reorganisation in primary care in Leeds, moved to NPCi full time, turned that certificate into a master's, and obviously highlight of my career, meeting you and Neil, of course, would have to be. But no, seriously, it was great. It really was good, and I think that was really when I think I have to credit you and Neil actually for first highlighting this whole stuff around shared decision making, decision aids actually, support tool. So I've kind of sort of taken that and run with it really. So then NPCi moved into NICE in yet another reorganisation, and I've been at NICE since. But yeah, shared decision making is my and that person-centered care is something I'm really interested in, and the associated things around like health inequalities, health literacy, and things like that.
Yeah. So I mean, we have that shared experience, don't we, of both of us, I think, being fairly good at doing educational stuff.
I'd like to think
And
so.
then being frustrated when we looked at the things like prescribing data and nothing was happening. So it then took us into understanding how humans operate as human beings, and indeed how they make decisions, either themselves or with other people. And that's why our interest in shared decision making and person-centered care came from. So I said at the start, didn't I, that we're going to talk about what we've called the lost NICE guidelines. So
Yeah.
just what do we mean by that, Andy?
Well, I think these are the guidelines that NICE has produced over a number of years. In fact, one of the ones we're going to talk about goes back to, I think it's 2012, something like that. And they're kind of like underpin everything else. So they're often missed, I think, because people are very busy. These are not, several of them are a few years old, some of them are longer. They're not disease, condition specific kind of thing. And often the urgent drives out the important. If you're really busy, you want to see what has NICE said about, I don't know, treating heart failure or something like that. But personally, I'm really concerned that people don't get the bigger context, the bigger picture.
Yeah, so the guidelines that we're talking about here are things like CG 138, which is the patient experience guideline. And there was also 136, which was for mental health. The medicines adherence guideline, clinical guideline 76. The medicines optimization guideline, which is NG5. The multimorbidity guideline, NG56, and also the NG197 on shared decision making. I'll put a link to all of those in the show notes, but they're the guidelines that we're talking about here, guys. Okay.
Absolutely. Well, there's one other really important piece of guidance that is, if you were to say, Andy, what's the most commonly overlooked piece of guidance? I'd say, I think it's this. And it's the bit that's on the overview page of every NICE guideline. And it says, I'm going to read it. It says, the recommendations in this guideline represent the view of NICE arrived at after careful consideration of the evidence available. Yet, NICE guidance are amongst the best in the world. Absolutely, because they have a really good methodology, really rigorous. It's not just faceless bureaucrats writing it, it's, you know, real health professionals and people with lived experience. So this goes on. When exercising their judgment, professionals and practitioners are expected to take the guideline fully into account. Absolutely. But alongside the individual needs, preferences, and values of their patients or the people using their service. It's not mandatory to apply the recommendations, and the guideline does not override the responsibility to make decisions appropriate to the circumstances of the individual in consultation with them and their families and carers or guardian. So that's the bit for the, you know, professional, patient-facing people. And it goes on and says, local commissioners and providers of healthcare have a responsibility to enable the guideline to be applied when individual professionals and people using services wish to use it. So it's not cookbook medicine. This is, to quote the great David Haslam, our previous chair, these are guidelines, not tramlines. If you routinely say, oh, I'm not going to take any notice of the NICE guideline on whatever, then you need to think very carefully about that. You need to have a jolly good reason for ignoring this really high quality guideline. But if you don't apply that in a person-centered way, you're also missing a trick, and you're missing what NICE actually says about how the guidelines should be used.
Yeah, so you often hear, don't you, that people say, well, it's mandatory to follow NICE guidelines or NICE guidance. And you and I used to put up this and say, well, this is what it says on the front of every piece of NICE guidance. There's nothing in here that's mandatory, apart from the stuff in the NHS Constitution that says there is a funding mandate for those technologies that have been approved by NICE to allow funding for those without any restriction in accordance to the NICE guidance, but also in the context that where the clinician and the person think that this is the most appropriate option for them at this point in time. So the only mandatory aspect to NICE guidance is commissioners have to fund it if the clinician and the person think it's the right option for them at this point in time.
Absolutely.
Nothing else is mandatory, Andy, yeah?
Absolutely, that's absolutely right. I mean, I've just read out the bit that's on the guideline pages. There is one which is slightly different, but basically says the same thing on all the technology appraisal and HST pages. So well, we won't bore listeners with that. They can read that for themselves. But that's the key thing. We really want you to take in these guidelines into account, because people have worked blooming hard to produce them, but they're guidelines and not tramlines.
I mean, and the other thing there is, I don't know a healthcare professional who doesn't want to do the best job that they can. Okay. In order for you to do the best job you can, if you look at the evidence for particular options and particular, therapies that are available, why would you not use a recommendation from an august body that has world-class processes, has taken into account all of the best evidence to inform that recommendation in your decision making with the person you're trying to treat? Why would you not do that if you're trying to do the best job you can?
Exactly. But it goes back to what is evidence-based medicine and Sackett and Co in '96. Best available evidence, the expertise of the professional practitioner, and the preferences, values, circumstances of the patient. And it's that sweet spot of all three of those coming together.
Yeah, well, so we would often put up that slide with the three intersecting circles, wouldn't you, with those three things. When David sat and his buddies defined evidence-based medicine, it was those three things, not just the best available evidence, but patients' values and preferences were always supposed to be part of evidence-based medicine. And I have to say, and I've got experience of this, having worked at NICE for 10, 11 years, NICE really take that seriously, the importance of that person-centered care. Often the focus is on creating those recommendations so that the options are the cost-effective options are evaluated and made available to people. But implicit within that, not always explicit, but implicit within that is that the importance of taking people's values and preferences into that. And the reason it's not explicit in every guideline is because, as Andy says, every piece of nice guidance is underpinned by those lost guidelines that we talked about at the start, the multi-morbidity guideline, the shared decision-making guideline, personal experience guideline, and others, as well as the boilerplate text on the front of every piece of nice guidance. So let's explore those lost guidelines a bit more than Andy. Well,
yeah, let's just take a quick canter through them. Obviously, we can't do justice to them now in detail, but this is, we've talked for years, you and I, about that golden hour of CPD that health professionals have got, a golden hour a week, really. Well, I reckon that reading through one of these and reflecting on it will take you about half an hour-ish, something like that. So perhaps a bit more, perhaps a bit less, depending on the guideline. And that's CPD time well spent. And of course, that's great for your revalidation. It feeds into your reflective diary. It feeds into your peer conversation as well. So there is something in it for you as a professional, as well as the care for your patient. So I think these things are really worth taking note of. But let's just have a quick canter through. So CG138, patient experience in adult NHS services. Not exactly the snappiest title of a guideline. I think we've got a bit better now in naming our guidelines. But anyway, that really kind of sets the scene for everything else. And as you say, that's about general NHS services. There are specific ones for mental health and for children and young people as well. So, but anyway, the CG138, it kicks off by saying, know the patient as an individual. I mean that, we've all moved on a long way from, the appendicitis in bed 36 kind of thing, rather than Mr. Jones who's got an appendicitis. But nonetheless, it's still about knowing the person as an individual and understanding their circumstances, their values, their preferences. And one of my favourite plays is Inspector Calls. And at the end, Inspector Calls says, all these people with their lives, their hopes and fears, their suffering and chance of happiness, all bound up with our lives and what we say and do and think. And I think the same principle applies here. As health professionals, whether you're seeing patients directly or like you and I, Jonathan, we're supporting people who are seeing patients directly, it's still that focus. And, what's a medicine's optimization, the roundel there, it's having the patient experience as the core. So talks about knowing the patient as an individual, talks about essential requirements of care, things like respect, talking about patients' concerns, and it talks about tailoring services for each patient by ensuring that people are able to actively participate in their care. And that is a theme that will come on as we come on later. So that's CG138.
It's interesting, Andy, isn't it? Because, and again, with a lot of these, you talk to people about them and they'll say, well, that's obvious. That's just motherhood and apple pie. We all know that. And then when you watch them do consultations with people, they don't do it. We recorded a podcast recently with Anne Jacqueline about the Hello, My Name Is campaign from Kate Granger. And Anne's appalling experience that listeners will have heard, where people didn't introduce themselves to her and didn't say, hello, my name is, and I'm the physiotherapist, and this is what I'm going to be doing to you today. It sounds really obvious and really easy. And a lot of the stuff in the patient experience guideline is obvious and easy. And yet it isn't done routinely, which is why we're talking about it today and trying to increase the awareness of it.
And this isn't to beat people up or criticize anyone, because we know how busy and stretched everybody is. My son's a undergraduate paramedic, my daughter's a midwife. I know from people who absolutely in the sharpest end of front line just how busy everybody is. And I don't want anyone to think that we're sort of saying, oh, you're not doing that very well. It's not that at all. It's just like, take a step back and just think and reflect. The reflective practitioner kind of stuff.
Okay, so what are the guidelines, Andy?
Okay, so next one I want to talk about really briefly is CG76 about medicines adherence. And again, that's things about supporting adherence, but also involving patients and service users in decisions about their care. But now we're into the three biggies for certainly from a medicines optimization point of view. So NG5 is medicines optimization, and there's a huge amount of resources in there. It talks about things like medicines reconciliation, safety, medication reviews, how to do a medication review, that kind of stuff. There's just so much in there, self-management plans, all that kind of stuff. So there's a really rich resource there for people who are kind of setting out perhaps on their pharmacy career, or indeed wanting to sort of do that reflection as well, or even sort of maybe you've got a new task, you've got a new job, you've got a new role to do. There's some great resources there that you can pull in and use.
Yeah, and the other thing I'd add to that, Andy, is, and I have lots of conversations with people saying structured medication reviews. People aren't thinking that they're a good thing anymore, so we're not going to invest in pharmacists' time or technicians' time to do structured medication reviews. The evidence is all in NG5 for why structured medication reviews are a worthwhile thing to do. And there's a health economic analysis within there as well. If you need to make a business case for why
it's all there.
Structured medication reviews are important, it's all in there.
Yeah. And people say, oh, it's 2015. Yeah. Well, okay, you show me that the evidence has changed.
All the evidence that's been published since then supports the notion that structured medication reviews are a worthwhile thing to do. I think the other thing to say that a lot of people aren't aware of at NICE, when you talk about NICE, is that NICE have an active surveillance team who are looking to see whether there's any evidence out there that has changed, that will impact on a recommendation. And if they don't change it, it's because it doesn't impact on the recommendation when they've looked at it. So that's why NG5 has not been updated since then, because there hasn't been anything worthwhile to change the recommendations in there. So people can be reassured by that NICE is up to date.
Yes, absolutely. So that's the first of the big three. Second of the big three is NG56. And if you read nothing else, I'd read this one, which is the multimorbidity guideline. And that really sets the whole context for that person-centered care, particularly in the context of multimorbidity. And if you'll indulge me, I'm just going to read the first 4 recs in the guideline, because they kind of tell you everything you need to know. It says, be aware that multimorbidity refers to the presence of 2 or more long-term health conditions, which can include defined physical and mental health conditions such as diabetes or schizophrenia, but also ongoing conditions such as learning disability, and also system complexes such as frailty or chronic pain, and also sensory impairments such as sight or hearing loss, and also alcohol and substance misuse. So when you think about that, lots and lots of our patients are going to have multimorbidity, and it's not confined to older people, younger people, children, young people, as much as people in their 70s, 80s, 90s kind of thing. So that's 1.1. It says, be aware that the management of risk factors for future disease can be a major treatment burden for people with multimorbidity and should be carefully considered when optimizing care. 1.1.3, be aware that the evidence for recommendations in NICE guidance on single health conditions is regularly drawn from people without multimorbidity and taking fewer prescribed regular medicines. And finally, it says, think carefully about the risks and benefits for people with multimorbidity or individual treatments recommended in guidance for single health conditions. Discuss this with the patient alongside their preferences for care and treatment. So that's it. That's the context. So the NICE guidance, I don't want to downplay all the rest of NICE guidance in any way, shape, or form. You really should be looking at what we've said about lipid management or ACS or whatever else. but it's in the context of that care for the individual person.
So I think, so for me, the important point here is, and you get this a lot, where will say, well, somebody's on 18 medicines. Why are they on 18 medicines? Well, because the NICE guideline told me to put, that's what it said to do. They had heart failure, so I had to put them on the 4 pillars that's within the heart failure guideline. And they had hypertension, and they had this, and they had that, and they had the other. And I have to do that, otherwise I won't get my QOF points and all the rest of it. And then you say, have you read the first 4 recommendations of the multimorbidity guideline? Because that basically says, no, you don't put people on medicines just because the guidance from NICE says it, because the context is the multimorbidity guideline. And then you have to make every decision in the best interests of the person, taking into account all of the things that matter to that person. And people forget that.
People forget that. And also QOF points is really important, but to get full QOF points, you don't have to have everybody on all those things. So absolutely that's right.
And I guess the other point about the multimorbidity guideline as well, and I remember having conversations with people saying, it was all really disappointing. They didn't tell us what to do with people with multimorbidity. So the expectation is somebody with type 2 diabetes, osteoarthritis, heart failure, hypertension, and what about depression? Well, there's no randomized controlled trials. There's no evidence for NICE to be able to base recommendations on, because those patients with those multimorbidities will not be included in the clinical trials that look at a new medicine for depression or whatever. They just won't be. So it's impossible for NICE to make recommendations within the multimorbidity guidelines specifically about how to manage individual patients. It talks about the principles of care here.
Absolutely, it's principles of care, because it can't take into account, even if we had this imaginary trial that says, well, what do you do for people with diabetes, hypertension, and depression, or whatever? It still doesn't tell you what to do for Mrs. Bloggs, who lives at the top of a tower block, is off her legs, and is worried about her cats, and and her son who lives 300 miles away, and all that kind of stuff. So you've got to tailor it to the individual person. So that, and one of the key things reiterated in the multimorbidity guideline is about that establishing the burden of disease and burden of treatment, but also establishing the person's goals, values, preferences, and how they interact with their treatment. And that is so important. And I just sort of digress slightly. So Professor Al Mully from Dartmouth, who I know you know, not Al Murray, pub landlord, that's somebody different. Al Mully has got, actually, there's a King's Fund paper from a few years ago, and he talks about this preference misdiagnosis. And in that, he sort of contrasts 2 women diagnosed with breast cancer. One of them has a lumpectomy, and it turns out that the tumor actually wasn't malignant, it was benign, and she didn't need it. That's a diagnostic misdiagnosis, and everyone really wants to avoid those. But also, he talks about another lady who did indeed have breast cancer. She did have a lumpectomy, but actually, having talked about it later with friends, and that she thinks, actually, I would have preferred something different. I would have preferred a different kind of treatment. And that preference misdiagnosis is kind of swept away. And there's other evidence, like there's another study that comes to mind where they asked, again, women with breast cancer, what their top priorities were, and oncologists and oncology nurses what they thought people's preferences were, and there was very little overlap. So that whole thing about assume makes an ass out of you and me. We need to understand what the person's goals and preferences are, really. And we could talk about Emmanuel and approaches to shared decision making in that. But that's the key, finding out what it's not what's the matter with you, it's what matters to you.
Absolutely. I mean, we've said that many times on this podcast, Andy, and it's absolutely fundamentally important. Al's work is fantastic. He'd actually make a great guest on here. I might think about that for future. So the last one is the shared decision making guidelines, and again we've talked a lot on this podcast, but again, why is it so very important, Andy?
How can you do all that we've said about giving person-centered care, taking account of what matters to them, unless you ask them? So the shared decision making guideline, there's some organizational stuff at the beginning which is relevant if you're a sort of strategic kind of person, but it goes into how to do shared decision making. It talks about a real structured approach to doing that. And we talk about 3-talk model. So we start off by introducing choice, and then we say, so I could say, so Jonathan, there's a couple of things we could do here. Can I explain them to you? And then I'd sort of say what the options were, and then we come to a decision. So there's choice, there's option talk, choice talk, decision talk, and that structure helps you work through that. And of course, some people will say, well, I don't, you decide, you're the doctor, nurse, pharmacist, whoever kind of thing. To which my response would be, well, I'm happy to do that if you want, but I still need to know what matters to you so I can make the right decision for you. So there's a lot of resources in that that help that.
Yeah, because I'm not you. That's why I always say I'm not you.
Yeah.
We're very, very different. We made different decisions about everything. We're dressed differently. We've got different cars. We live in different parts of the world, or whatever. We have different values and preferences. But I can tell you what your options are if you tell me what it is that really matters to you. And that's got to be the start of every conversation. Absolutely. I mean, I think the shared decision making guide, as you know, we helped lots with that, didn't we, Andy?
Yeah.
The construction of that with people like Victoria Thomas and formerly at NICE, who was an absolute star of that. And then we also produced a whole load of e-learning materials, didn't we, with Keele, with Simon Jacklin and Jess Thompson at Keele, which are still available on the NICE Shared Decision Making Guideline page, aren't they? And again, if people want something to get up to speed in their golden hour of CPD a week, you could do a lot worse than do that e-learning module from NICE, or indeed the CPPE shared decision making module, which I think is great as well. Again, we'll put the links to that in the show notes as well.
Yeah, absolutely. Well, the NICE one is free. It's real bite-sized chunks. You can do it shortly, and of course at the end it links to the last module in that links to Keele's virtual patients, so you can actually have a go at doing shared decision making with people where you can't upset them. They don't get bored, they don't get tired, they don't get cross with you. You can just practice. It's brilliant.
Exactly. Andy, that's been really, really useful. I think, and I do think when we had this conversation a few weeks ago, we did say, people do forget about these things, and I think the other thing to say is, having worked at NICE, constructing recommendations, the people, the medical writers and others who put these together after the committee has been presented with the evidence and had a discussion about the evidence and all, the recommendations are written in the context of these guidelines. Otherwise, if you think about it, guys, NICE guidelines are too long already. Can you imagine how long they would be if every recommendation was prefaced or suffixed by the important principles underlining every recommendation that's made? It just wouldn't be readable. It wouldn't be usable. So it's really important that people are aware of these, as you say, so-called lost guidelines. Just to finish off, Andy, I guess first of all, is there anything else that you think we need to cover here? Or
I mean, I could bore for England on this stuff. I think I hope that's given people a bit of a taster, and I would encourage people to go and have a look at them. So we always used to finish NPC things with, what 3 things should I do?
So let's do that then. So what 3 things do you think people should be aware of to try and improve awareness of this, Andy?
Well, I think number 1, I'd say read the guidance. And if you're going to pick the top 1, I'd probably say, well, top 2, I'd say read the multi-morbidity guideline and the shared decision making guideline. That's number 1. That's number 1 to do. Number 1 thing to do. Next thing to do is practice and reflect on this and see how it fits in your actual practice. Check what you're doing. Ask patients. There are other tools and things we could talk about, SDQ9, SDMQ9 and SDMQ doc and things like that. and Collaborate and all these other tools that you can help to get some feedback from the people that you look after. If you're not, so that's number two, and then number three kind of depends on whether you're a sort of patient-facing or in a more strategic role. And I think that's that reflection. And what could you do differently? What could you do differently if you're seeing patients? It starts off on another little spiral of what three things do I need to do now, having established what I probably ought to be doing, what I am doing, and then the thing is, what should I stop doing, start doing, or do more of? And that's if you're seeing patients. If you're in a more strategic role, it's like, well, what can I do to help the people that I'm supporting do those different things? So that's my recipe.
Brilliant. I really like the idea of getting feedback on what you're doing. There's a little bit, I think, well, I don't think, this has been shown through the magic collaboration with shared decision making. It's a bit of a Dunning-Kruger effect here with clinicians who think they're really good at shared decision making, but actually if you video them or you watch them or they ask for feedback, they're not as good as they think they are at it. So how do you find out if you're not very good at something? You ask for feedback, or if you can be in the circumstances, get somebody to do an accompanied consultation with you and debrief with them afterwards. That could be enlightening for people along these lines, can't it?
Well, I guess you could put in the show notes the links to those things that I know people use in practice. I know of a physio referral service that routinely use Collaborate and SDMQ9 to evaluate their service. And actually, I've got a fourth thing, and that's read the section. If you don't read anything else at all, read the section in the shared decision making guideline around communicating risks and benefits, because that is the one thing that we could all do so much better. And I've been on the receiving end of well-meaning but actually not very good communication. I was talking about a procedure, I was deciding whether to have a procedure or not, and honestly, it was all over the place. The benefits were in percentages, not balanced. The harms were all in numbers needed. I couldn't work it out. I had to write it all down and draw out a little icon arrays to make sense of it myself. And I kind of like to think I'm pretty numerate. So focus on the risk communication. That'll be really good. There
Absolutely.
We go. 3.5, 4.
Thank you so much, Andy. Yeah, 3.5 to 4. That's probably allowed. You can get away with it because you're my mate. And it's also really, really important. Andy, it's been an absolute pleasure. Thank you so much for taking the time to share your wisdom and knowledge with listeners. Hopefully you enjoyed this, listeners. Maybe we'll get Andy back again in future and we can talk maybe in a bit more detail about shared decision-making guideline and risk communication, Andy?
Happy to do so. More than happy to do so.
Fantastic. Thanks for listening, guys. See you soon. Bye.
Cheers. Bye-bye.